All right, thank you guys. So I'm going to talk about our pulmonary valve options that we have available in the US, and I'm going to talk about some of the ones that are available in the market that we don't have in the US. And then I'm going to talk about some of the newer self-expanding valves, which I think are the interesting new things on the market for the dilated RVOTs. So these are the objectives. I'm not going to read it because we'll just go through it in the interest of time. All right, so pulmonary insufficiency, it's a really prevalent thing. Up to 78% of people just hanging out in the world have some degree of pulmonary insufficiency. But any patient who's had some sort of surgery on their RVOT or on their pulmonary valve or had a balloon pulmonary valvuloplasty as a kid also has more significant pulmonary regurgitation, which is kind of key to what we're talking about here. Just an example, you can see, free pulmonary regurgitation. You can see what their pressure half time is. So using your echo to determine the degree of pulmonary insufficiency is very important. Cardiac MRIs are kind of the gold standard when you're looking at patients with pulmonary insufficiency and looking at RV volumes and regurgitation fraction. And when deciding if a patient needs a pulmonary valve replacement or meets indication for a pulmonary valve replacement, you're using your cardiac MRI guidelines. And looking at just kind of the regurgitation fraction, any patient with greater than 40% regurgitation fraction has severe pulmonary regurgitation. And then also looking at both your RV volume and your LV volume. The original guidelines were all made for TET patients, post-surgical TET repairs, that had transannular patches and free pulmonary regurgitation. But we're finding that we're putting valves in plenty of other patients, so using the RV to LV volume ratio has become more important and kind of branching away from the initial GIVA criteria for TET repairs. So just touching a little bit more on what I was just saying. So free PI gives you RV dilation. It's a big volume load on the heart, on the right side of the heart, which, as Dr. McCulloch had said earlier, is not used to seeing high volume, high pressure. Your right ventricle is not created like your left ventricle. And when you end up having this happen, over time, your heart does not like it and you get RV failure. And it's trying to prevent RV failure and doing something before that by giving someone a competent pulmonary valve, which is key. So I think the biggest effect of pulmonary insufficiency is these patients don't know that they're symptomatic from their pulmonary insufficiency. All of these patients had some sort of procedure when they were a younger patient, when they were a little kid, and they have adapted their entire life to living with free pulmonary regurgitation. All of these patients, the second you put a competent pulmonary valve into them, they feel better. So I think using symptoms, we use symptoms, and I'll go through some of the indications and kind of how we go down the pipeline to get to a pulmonary valve replacement. But when someone says they're symptomatic, they truly are symptomatic, but everyone who says they're asymptomatic has also been symptomatic. So these are the TET guidelines. These are adapted from our ACHD guidelines, the most recent one being 2018, but these are the GIVA criteria. These came out well before that, and these have not changed. This criteria is solely for TET patients who have had transannular patches. We do apply this to other physiologies, pulmonary stenosis, pulmonary valvotomies, people have had balloon valvuloplasties, and some patients with RV to PA conduits, but really these were made for TET patients. And even though I'm a pediatric interventionalist, I'm using these in peds patients and adult patients. This criteria was solely made from adults. We're just applying it to the pediatric population, kind of like everything else we do. So patients kind of start off with mild PR. They don't get a pulmonary valve. They just follow up with their cardiologist. I cut it off because it's so not important. Patients with moderate or severe PR, then you need to talk about symptoms. If they have symptoms, they get a pulmonary valve. And like I said earlier, they all have symptoms, they just don't realize it. They all should get a pulmonary valve. As one of our surgeons always says, you were made to have a competent pulmonary valve and the surgeon messed it up, so why not have a competent pulmonary valve later in life? However, if they do not endorse symptoms, what you want to look for is any two of the following here. And these are widely available. This is straight from the GIVA criteria, looking at RV volumes, looking at QRS duration, and if you meet two of those, you get a pulmonary valve. The other thing is if you have sustained arrhythmias, that's where you also want to start considering putting in pulmonary valves in patients as well. So RV to PA conduits, these are a little bit different. So I think of the previous case when you have free pulmonary regurgitation as a pulmonary regurgitation problem. You do not necessarily have stenosis, you have regurgitation. These patients have stenosis and regurgitation. And what valve you pick very much depends on if you have a dilated outflow tract and free pulmonary regurgitation, or if you have a conduit or stenosis and you're thinking more about the balloon expandable valves that we have on the market. Again, these patients, moderate or greater PR, moderate or greater stenosis, and then any sort of reduced functional capacity. So again, you're back to symptoms. If they have symptoms, they get a pulmonary valve. The RVOT spectrum, so this is kind of what I've touched on a little bit already. Native RVOTs, so patients that have had transannular patches, have had episodes of endocarditis that result in free pulmonary regurgitation, patients that had congenital PS that either had a balloon valvuloplasty as an infant or a surgical valvotomy as an infant, those all have free regurgitation, dilated right ventricles, dilated outflow tracts. As opposed to the bioprosthetic valves, the conduits, those patients usually have a fixed stenosis and you're putting a balloon expandable valve in those patients. These are just some of the valves that have been out there from a surgical standpoint. I always like to tell my fellows, and I like to tell everyone else, there's a great app that you can get both for iPhones and for Androids called Valve in Valve app, and using that app will tell you what valve is in if you know what valve is in a patient, you find that valve in the app, it will tell you if you can break it, it tells you if you can expand the valve, and it gives you a list of all valves that fit inside that valve. It's made for the aortic position, but we just use it for the pulmonary position because we don't really have many approved valves for the pulmonary position. So this is our cocktail of valves that we have available now. The top two being the Medtronic Melody and the Edwards Sapien. Those are your balloon expandable valves. Everything else below that, those are your self-expanding valves, including the Altera pre-stent, and those are made for the dilated outflow tracts. Balloon expandable valves, they've been around for a long time. I'll touch on them briefly, but really I'll go through a case of using one of the Harmony valves that we've done at our institution and kind of, what these valves are and how they're kind of opening up a whole new patient population for us in the cath lab. So these are the two current valves, again, Melody and Sapien. Melody valve's been around for a long time. 2007 was when it was first performed in the US. We have a lot of years of data and research that have been studying the Melody valve specifically. Medtronic's done a fantastic job keeping a registry open and following these patients long term. These are for patients that have stenosis. Moderate PR or greater, but also a mean RVOT gradient of greater than 35 millimeters of mercury meets indication for these to be placed. They come in two different sizes, the 20 and the 22. It's bovine jugular veins, so I always think it's interesting that for every cow that gets slaughtered, they look at two of their jugulars, and it's basically 1 in 100 jugular veins are actually used in the study. So that's 50 cows, so one valve coming out of 50 cows, which I always think is interesting. The TPV-22 is by far the most common one. It performs really well at an under-deployed size, but you can also deploy it all the way up to 26 millimeters, which is nice. The TPV-20, it's a little less common. It's actually harder to find those valves in cows because cows are just getting bigger. But we use the TPV-20 for some of our smaller patients, but we also use those for surgical Melody valve placements. So when our surgeon needs to do a Melody valve replacement in a small child, we'll come into the OR and do a hybrid procedure using the TPV-20. These valves have really poor radial strength. That's kind of a really important thing. Their valve framing is really weak and they fracture. So by far, right now, everyone who puts these in, you pre-stent before putting these in. Post-approval study, obviously we were very successful. 95% of these got deployed. Patients came to the cath lab for a pulmonary valve, they got a pulmonary valve. And most patients did not have much gradient after, gradient less than 35, and most did not have any free PR, or most of them had mild PR. Freedom from intervention at 5 years was 76%. Again, these are the early studies. A lot of that was because we didn't realize we needed to pre-stent these valves. Since pre-stenting, that rate has gone down. The kicker with this valve is the endocarditis rate. And that's by far the biggest thing with this. So in their early studies, the one that came out in 2013, a 13% endocarditis risk for these patients. That's obviously significantly higher than we ever would have wanted it to be. On the newest data that's come out, it's down to about 10%, but it's a 2% annualized per patient risk, which is significant. I think when I talk about the sapien valve, you'll see that it's significantly lower than that. So my personal preference is to put a lot more sapien valves in. So the sapien valve has 4 different varieties now. We're up to the Resilia. XT was the first one. That one's this one here. You can see this one is a cobalt chromium frame, and you can basically see that big change from the XT here to the first S3 is this skirt along the bottom. This valve is a tri-leaflet bovine pericardium valve. This was made for the aortic position that we are now using in the pulmonary position. The whole reason why the skirt exists is to stop paravalvular leak. So the valve really hasn't changed too much from here to here. It's just kind of how they use it for aortic changes, and then we just adapt it for the pulmonary side of things. This has much better radial strength, so we don't pre-stent with this valve. If we have a fixed narrowing or a fixed stenosis and we have a landing zone for this valve, we just put this valve in. We don't pre-stent if needed. And then this valve comes in a 20, 23, 26, and 29 millimeter diameter, and it can be overexpanded to 31 millimeters. With all balloon expandable valves, you have to get arterial and venous access. You have to check your coronaries because you risk coronary compression when you're inflating these valves. This was out of Cincinnati in 2020, but it's a big multi-center registry. Serious adverse events was 10% when this was first coming out, and that was because of the coronary issue and making sure that they check the coronaries. A little bit of tricuspid valve injuries. Embolization was a little bit higher in this, but again, this is the early studies. But there was, at the 12-month follow-up, you can see here, this is the most important thing, less than a 1% incidence of endocarditis. So 10% incidence with one valve, less than 1% with this valve. And it probably has to do with the fact that this is a designed valve in the lab. They're taking the pericardium and making the valve leaflets as opposed to using a natural valve. And there's some idea that some of the, it being a natural valve, there's some discrepancies in the valve cusps or the leaflets that causes increased risk of endocarditis. So a lot of people are moving towards this valve if you're going to do a balloon expandable valve. So this was from one of my mentors in Colorado when I was there, Dr. Zabla. So this was a really nice kind of just algorithm of how we place our valves. So when you look down this whole thing, right away, someone meets an indication, usually from an echo guy, from echo and from talking to them in the clinic. You get a CT or an MRI. Then they decide, yep, we want a cardiac cath to get a pulmonary valve. Next thing you know, what do they have? Do they have a native RVOT? Do they have a conduit? Or do they have a prior valve? RV to PA conduits, prior valves in places, those are pretty easy. Those get balloon expandable valves, not a problem. However, if you have a native RVOT, and your native RVOT is on the larger side, and I think this should even be updated to something smaller than this, but if you're above about 25 millimeters in diameter, you're gonna start thinking about the new balloon, the new self-expanding valves, not the balloon expandable valves. That's your Harmony, that's your Altera. In America, we'll have the Venus P valve here shortly, so we'll start doing those at University of Virginia as well, so we'll have 3 options of valves that we have. After that, it's all the same long-term management for all the valves. It doesn't really matter. But I think this is a nice little algorithm of how you go down what valve you're gonna pick. So the dilated RVOT, I think this is where more and more valves are being placed where these patients needed to have surgeries beforehand. Either a surgical valve placed or a procedure where the surgeon would kind of narrow down the RVOT and then you would place a valve there. Basically, as we've kind of talked about, these are the TET patients, these are your pulmonary stenosis patients. They have big dilated RVOTs. The big thing with these patients is prior to the procedure, they need a gated CT scan. So they'll all have MRIs to show their RV volumes, but they need a gated CT scan because you need to see systole and diastole. And then what we do once we have the CT scan is we send it off to the two companies that we're currently using, either Edwards or to Medtronic, and they give us a report back of how the valve is going to fit. So again, touching on these valves, the self-expanding ones. So the Altera adaptive pre-stent, it's self-expanding. It's a partially covered stent. The distal portion is uncovered, which allows flow to both pulmonary arteries, so you can place this nice and high in the pulmonary bifurcation, but still have flow to both pulmonary arteries. But then it has this hourglass shape, like they all do, which gives you a narrowing of where your valve is going to be placed. You put a 29 sapien inside this stent. It can accommodate 29 sapien that can then take multiple other 29 sapien. So hopefully these patients have this put in and then they get multiple valves in the cath lab for the rest of their life and don't need a surgical operation. Like all of these valves, or I take that back, like the two valves we have available in America, your biggest constraint is the RVOT length when you think about pediatric patients. These valve housings are tall. 48 millimeters here, the Harmony valve is even taller. So you need the vertical length in order to place these and not interfere with the RV myocardium, which is our big worry. This was just, again, out of Cincinnati's group with their early feasibility study. These were the patients that were included in it. CTs were performed. 3D models were printed originally, so this is kind of what you get back from the company. This is not a full comprehensive fit model that you get back, but this is kind of a little piece of it. And back in the day, when they first started doing these, they would actually send you a 3D model, hollowed out 3D model, of both systole and diastole, and everyone had the valve on there, just a dry model of the valve, and you would place the valve into the model to see how it would fit. Here, this is just examples of doing that. They don't do that anymore. They do all computer modeling for everything, so we don't get these prints anymore. The Altera valve, where it differs significantly from the Harmony valve, is with the Altera pre-stent, it's a pre-stent. So you have to put the Altera pre-stent in, take your whole system out, and then do your traditional way of putting in a Sapien S3. So it's a two-step process. There's definitely been issues with that by causing, as you recross your freshly deployed stent, pushing the pre-stent out of the either the main RVOT and pushing it to an LPA or an RPA, or the stent moving either backwards or forwards. The Altera pre-stent system has also had episodes of coronary compression, so when I put this in now, I do check coronaries, even though it's a self-expanding stent, where traditionally you would think you wouldn't need to check coronaries. And there's also been episodes of erosion with the Altera pre-stent. So some things that make it a little bit more of a negative when it comes to what valve I'm going to place in patients. So the Harmony, which is made by Medtronic, comes in two varieties, the TPV22, which was the first one that they created, and then the TPV25. This is a valve on a stent already. One-step process, very slick. I'll run through a case. This is porcine pericardium, self-expanding nitinol frame, 22 millimeters or 25 millimeters at the valve housing. 51 or 55 millimeters in length. So the TPV22 is narrower and longer. The TPV25 is kind of this fatter and squatter valve. The TPV25 fits about 95% of the patients that this valve has been implanted in. Even though TPV22 was the first one that came out, it took so long for this valve to get to the market because TPV22 fits so few patients. So actually, while they were trying to get this valve to the market, they were designing the TPV25 because they were realizing the TPV22 didn't fit most patients. I've personally never put in a TPV22, and I've seen it done once because it's so rare that we put that valve in. The TPV25 just fits everyone. So after you get your gated CT scan, you send it off to Medtronic. The Edwards system looks very similar to this. So this is a case that I'm going to do next week, actually. So this is a 15-year-old patient. After you send your CT scan, you get this kind of comprehensive modeling coming back. It talks about both valves, TPV22, TPV25, and you get to see kind of this landing zone or where the valve will fit. This is a kind of a longer outflow tract, so we have plenty of length to deal with either the 55 or 51 millimeters of length. 21 millimeter landing zone. So that gives us a nice long area where we can put this valve, where we think we can have what you look for here is green on green. So green on green means both the distal and the proximal portion of the valve will be opposed in both systole and diastole, and the valve has a very low incidence of moving in that case. If it didn't fit green on green, I'll show a little in a couple other slides, you get yellow, which means maybe it's gonna work, and then you get red, which is gonna be no apposition. But green on green usually means good. Yellow on green can sometimes work, red on green can sometimes work, or vice versa. So you take this with a grain of salt because you actually have to think about, you know, where you want to place the valve, how you want the valve to sit, and you can actually, you don't necessarily need green on green, and if you have something different, just say no. So you can fit a lot of these valves in a lot of patients. You get these nice 3D models that get created that show you kind of ideal projections that you're going to want from your biplane angiography. And you even get simulated angiograms. These are from the company. They basically take the CT scan and make simulated angiograms. So you can see almost always it's an RAO crani projection from your AP camera, and then straight lateral. And those are usually your two best viewpoints. You can do this in a single plane lab, but I highly recommend a biplane lab. Our reps always want us to do this in a biplane lab, but sometimes that's not available, so we do this in a single plane lab. They also put the valve into the model here and show you kind of how the valve will sit in the model, which helps you do some case planning and thinking about this. When you have a really long landing zone, they give you this model where they show you kind of at the midpoint and then a lower down position for the valve. They always send you this GIF, which I think is really nice. As you can see, the TPV22, you're getting a lot of red on green. And then you're going to see when it does switch to green up here, it's going to be red down here. As opposed to the TPV25, in our long landing zone, has a lot of green on green. So as this is moving through, it takes a long time for you to actually lose your apposition on the bottom portion of this valve. So this is nice because no matter what, I'm going to be stuck in the top of the PA bifurcation, and I'll be able to get this valve to sit in place here through the rest of it. These are always nice to kind of compare the 22 versus the 25, and you'll see almost always the 22 never works. So the case setup, as I just said, biplane lab is always best. You always want your patient's arms up. I even have our anesthesiologist turn the patient's head to the left because I know it's going to be from an RAO crani projection. So just have all that set up beforehand. 26 French venous system for the venous access. If we do this through a dry seal, a 26 French dry seal sheath, and the reason why is that we're able to recapture the valve. Even if you've deployed the entire valve, haven't released the delivery screw yet, you can still recapture the valve through the 26 French dry seal. That is not in their IFU, and they will not tell you that, but everyone knows that. And I've personally had to do it, so it works. In their IFU, after you release just the first row and second row, they say you can't recapture after that and you need to call surgery, but that's not true. We do not test the coronary arteries, and I like to use ice after the case just to look at paravalvular leak and make sure there's no significant gradient at this valve. So this is a case we had recently. The case I showed earlier we haven't done yet, so I had to show you a different case, but this is a nice one where you can see significantly dilated right ventricular outflow tract, PAs. Both PAs are massive, and their main PA is massive here. The interesting thing is when I was an interventional fellow and learning pulmonary valves, I was always taught wire position in the LPA. Always, always, always. It was drilled into my head, wire position in the LPA. With the balloon expandable valves, it's wire position in the RPA. Every single time. Wire position in the RPA. So it's completely changed kind of the convention of what we do, but these valves, you don't need to get your long sheath that distal, their delivery system's much nicer, and having your wire in the RPA really helps you know when you've branched across or flowered across the PA bifurcation, which I'll show you here. So we now have our delivery system out. This is the Harmony delivery system. You can see our dry seals all the way back here in the RA-IVC junction. And you can see that you have nice sinuses for your pulmonary valve. You can see maybe a little pulmonary valve residual leaflets. Our wire is still nice and distal in the RPA. Our carrot, which is the kind of the delivery anchor, is nice and distal in the RPA as well. Here we've taken out 1 and 2, rows 1 and 2 of this valve, which are open in the RPA, but not fully across the branch PAs yet. And when I deploy these valves, I want to keep these valves very high in the PAs. You want to be away from the RVOT to decrease your risk of ventricular tachyarrhythmias, basically, from the stimulation of the valve hitting the RVOT. So once I have this kind of deployment here, I take another picture just to prove where the back of the PA bifurcation is. And what I do is I just push the wire. And as I slowly push the wire, the whole system kind of comes back and jumps across the bifurcation. And by being in the RPA, you get that tactile feedback of your system jumping across the PA bifurcation. And when you have that, you know you're sitting really distal in the PAs, and you know your valve is going to sit nice and high, which is what we want. If you were in the LPA, which is a much straighter position, you'd lose that tactile feedback and you don't actually feel it quite as much. So it just makes your deployment a little bit harder than it needs to be. And these are nice quick procedures, so why not make it as easy as possible? Take another picture here. We haven't deployed any more of the valve. All we've done is push the wire, and the system has come back to be at the top of the pulmonary bifurcation here. And once I see this, I can just let the rest of the valve out. I just basically uncover, and here you have their valve sitting down lower. The valve always is going to want to sit lower. It's going to fall down to where the shoulders are of your PA bifurcation. So if you look here, the LPA shoulder is kind of sitting where we want it to be in the LPA shoulder, but we are not opposed at all on the right side, the kind of lesser curvature here to the right PA. You can see we're not sitting at the shoulder there. But that's okay. The valve is going to want to go where the valve wants to go. You just need to make sure you're high enough that the valve doesn't fall all the way into the right ventricle. It's never going to when you're this high. Take another picture, and then basically you start uncoiling your valve. Once you uncoil your valve, you can see we're sitting in that LPA shoulder still really nicely, but we've come down to the RPA shoulder. And we were using the shoulders of the bifurcation of the PAs to basically keep our valve anchored there from a distal standpoint. And then the nitinol frame just does what nitinol does, and it opens up over time. And it's going to just start occupying all this space. You see plenty of flow going through the valve. You don't see anything going around the valve. And you can see that we're well out of the RVOT. You don't want to be down low. Annular implants are okay, but you're going to have some ventricular arrhythmias associated with it. You have that, that's okay. You start your patients on beta blockers, and usually over a month, as their RV gets smaller by having a competent pulmonary valve and remodels, that arrhythmia goes away. You take your system out, you take one more picture. Of course, we use a pigtail catheter that then causes catheter-induced pulmonary insufficiency, but we're okay with that because we know it's us causing it. But you can see the valve is, again, sitting really nicely at that PA shoulder, and you don't get much PI whatsoever, and the valve is still sitting really nicely distal in the pulmonary artery. This was the patient before. You can see free pulmonary regurgitation. We keep all of these patients overnight. We monitor them on telemetry just to make sure they don't have any ventricular arrhythmias. And then the next morning, we get an echo, and you can see no pulmonary regurgitation. I like to have these patients get a follow-up cardiac MRI 3 to 6 months after the procedure, just so we can prove that their right ventricle has remodeled and has come back down to a normal size. You always have an MRI beforehand, get an MRI after, just to make sure that they have normal RV volumes again. All of these patients, like I said earlier, feel so much better the next day. They don't realize how symptomatic they were. And now that we have balloon expandable valves and self-expanding valves, we're able to treat kind of the whole RVOT spectrum and kind of, of course there's obviously the need for the surgeon at different times, but we're trying to take more and more of these away and do more and more of these in the cath lab. And with that, just the menu once again, but that is it. Thank you, guys.